welcome to my channel. In this video I'll be focusing on the basics of the renal system and the uses of diuretics along with their classifications. As always, please don't forget to like, subscribe and share, as it does help with the channel. The video may be slightly long, so feel free to skip to the section that's most relevant to you. I've split the video into introduction of the renal system, brief physiology of the nephron, possible uses of diuretics in heart failure and hypertension, and classifications of diuretics. So let's start by giving ourselves a quick recap on the anatomy of the kidneys. These are bilaterally shaped organs which are situated in the lower posterior side of the abdomen. Their functions are to excrete waste products from the blood and also regulate the water and electrolyte balance. From this picture of the kidney I drew out earlier, you can see the various internal structures that form the kidney. So on top over here you've got the renal capsule. Here you have the renal medulla and pyramids. In the middle over here you've got the renal pelvis. The major calyx is situated over here. And the minor over here. And urine from the kidneys is excreted through the ureter down here. In terms of the blood flow to the kidneys, the blood flows via the right and left renal arteries, which then branch into small arterioles. The pressure of the blood is usually high at this state, which flows into the glomerulus right here. It enters through the afferent arteriole and leaves via the efferent arteriole. In order for me to explain the next couple of sections much better, I've drawn out this single nephron. So why is the nephron so important? Well, the nephron is the functional unit of the kidney. It begins from the Bowman's capsule, which is where the glomerulus sits. The endothelium of the glomerulus contains pores and slits, making it suitable for filtration. This allows filter of substances and water from the blood into the nephron itself. The Bowman's capsule then opens into some sort of tubular coiled region, also known as the proximal convoluted tubule, which is this section over here. In the proximal convoluted tubule, large amounts of reabsorption occurs, where water and solutes are transported back into the bloodstream. So here the orange arrows show active transporters and the blue arrows show the passive transport of ions. The driving force for reabsorption in the proximal convoluted tubule is sodium. An example of an active transport is the sodium potassium ATPase pump, which pumps out intracellular sodium ions, allowing the movement of sodium into the cell from the lumen of the tubule. The concentration gradient of sodium allows the passage of other molecules as well, such as glucose. This allows the glucose molecules to be transported across the membrane against the concentration gradient. So for example, you've got SGLT transporters, which move glucose together with two sodium ions across the membrane. So these glucose molecules are then able to cross the opposite membrane via facilitated diffusion. Another thing to remember is that as well as reabsorption, secretion also occurs in the proximal convoluted tubule. The tubule is able to secrete different compounds such as organic acids, drugs and toxins, and hydrogen ions, which are important for maintaining the acid-base balance. The hydrogen ion secretion allows reabsorption of bicarbonate via the use of carbonic anhydrase enzymes, which I'll talk a bit more about later on. Now, if we move further down the nephron, the proximal convoluted tubule then begins to thin and straighten out into the loop of Henle. This is the thin descending limb, and this is the thick ascending limb over here. In the thin descending limb, there's a high permeability to water with low amounts of urea, sodium, and other ions being reabsorbed too. The primary site of sodium reabsorption in the loop of Henle is this thick ascending limb over here. So unlike the thin descending limb, this limb is impermeable to water. You also have sodium active reabsorption, with the driver being sodium potassium ATPase pump. Sodium then moves into the cell from the tubule lumen itself through the NKCC2 transporter, which is the sodium, potassium, and 2-chloride ions on the membrane, which moves sodium, potassium, and chloride ions. So further along the nephron, the ascending limb of the loop of Henle then coils again to form another region called the distal convoluted tubule. The role of the early distal convoluted tubule is the absorption of ions, which include sodium, chloride, and calcium. Movement of these ions is dependent on the sodium potassium ATPase transporter. The sodium concentration gradient allows sodium to enter the cell from the lumen of the distal convoluted tubule, which occurs through the symporter, which is the sodium chloride cotransporter alongside chloride ions. This then empties the urine into the collecting duct as shown here. The main role of the collecting duct is the reabsorption of water, which is usually through the action of a hormone, which is an antidiuretic hormone. The hormone itself is stored in the posterior section of the pituitary gland, and there are also aquaporins in this area. The late distal convoluted tubule and the collecting duct are usually composed with two main cell types. These are the principal cells and the intercalated cells. So the principal cells are involved in the uptake of sodium ions and the release of potassium ions. They are driven by the sodium potassium ATPase pump, whereas the intercalated cells, they assist in the acid-base control. They control the levels of hydrogen and bicarbonate ions. The difference between the proximal convoluted tubule and these cells in this area are that they actively secrete hydrogen ions into the lumen against the concentration gradient. Now we will move on to the involvement of diuretics in the kidneys. So first of all, diuretics are compounds that increase the amount of water and sodium being expelled from the body. So in other words, they cause diuresis. They're commonly used to treat patients with cardiovascular complications such as heart failure and hypertension, although they can be used for other conditions that require diuresis for their control. We'll begin with carbonic anhydrase inhibitors. This classification of diuretics suppress the activity of carbonic anhydrase enzyme in the proximal convoluted tubule. An example of this classification is acetazolamide. When the enzyme is inhibited, it allows bicarbonate ions to build up and cause some sort of bicarbonate wasting. This leads to the reduced ability to reabsorb sodium in the exchange for hydrogen ions, and hence leading to mild diuresis. Some of the indications include chronic simple glaucoma, as it reduces intraocular pressure by decreasing the formation of the aqueous humor in the eye, and it could also be used as an adjunctive treatment of edema due to congestive heart failure. It's important to remember that the carbonic anhydrase inhibitors, they are weak diuretics, so they're very rarely used for its diuretic effect. Route of administration, so you've got topical, oral, and parenteral. So the topical are usually used as eye drops. So you've got brinzolamide and dorzolamide. Brinzolamide is usually used twice daily for glaucoma, and dorzolamide usually 1-3 times a day. Oral form can be used as acetazolamide tablets and parenteral acetazolamide intravenous. Side effects, well, because there's a loss of bicarbonate, there's a chance of metabolic acidosis. The next classification of diuretics are osmotic diuretics. An example is mannitol. So mannitol is filtered in the glomerulus but not reabsorbed by the nephron itself. Within the nephron, its main effect is carried out on the parts of the nephron that are freely permeable to water. So for example, the proximal convoluted tubule, you've got the descending loop of Henle and the collecting tubule. The main effect is to increase the amount of water that's excreted. So it induces diuresis as it's not reabsorbed in the renal tubule. This then increases the osmolality of the glomerular filtrate, and then therefore causing facilitation of excretion of water and inhibiting reabsorption of sodium chloride and other ions. Some of the indications include cerebral edema, so it reduces intracranial pressure by a reduction in the viscosity of the blood, and therefore it allows oxygen to be delivered to the brain. Also raised intraocular pressure, so it reduces some of the intraocular pressure, and as always, diuresis. One another indication for this is adjunctive treatment for cystic fibrosis, so it can be used as a dry powder inhaler. So some of the contraindications for this are severe cardiac failure and severe dehydration. Some of the side effects include cough, vomiting, and headache. Now we'll talk about loop diuretics. So examples include furosemide and bumetanide. Loop diuretics act on the NKCC2 transporter, which is the sodium, potassium, and 2-chloride cotransporter, situated in the thick ascending limb to stop their reabsorption. There is competitive inhibition at the chloride binding site of the cotransporter, which stops transport of sodium from the lumen into the interstitium itself. This causes the lumen to become more hypertonic, whilst the interstitium becomes much less hypertonic. This therefore reduces the osmotic gradient for water reabsorption throughout the nephron. These diuretics also inhibit the sodium, potassium, and chloride transporters that are situated in the macula densa. The diuresis leaves less water to be reabsorbed into the blood and results in the decrease in blood volume. The secondary effect of loop diuretics is to increase the production of prostaglandins, which would lead to vasodilation and increase blood supply to the kidneys. Some of the indications include edema associated with congestive heart failure, resistant hypertension, pulmonary edema, and diuretic resistant edema. The diuretic resistant edema can be treated with a loop diuretic combined with a thiazide diuretic. It's also important to remember that loop diuretics are often more effective in patients with impaired kidney function compared to the use of thiazide diuretics. Some of the cautions, they can exacerbate diabetes and gout. Some of the side effects include mild gastrointestinal disturbances, dizziness, postural hypotension, and electrolyte disturbances. So with electrolyte disturbances, this is really important as they can cause hypokalemia, which could increase the toxicity of certain drugs such as digoxin, which would need monitoring. For pharmacokinetics, They are absorbed in the GI tract and are usually given via the mouth. May be given IV in urgent situations, for example in pulmonary edema, as it produces relief of breathlessness and reduces preload much more sooner. When taken orally, they act within 1 hour. The IV, the peak effect is usually within 30 minutes, and the half-life of the drug itself is 2 hours. It's eliminated via urine, and 95% is bound to plasma protein, so therefore it has a low volume of distribution. Another thing to remember with loop diuretics is that they have a ceiling effect where there is a maximum level of dosage, and any more increase in the dosage would not increase the clinical effect of the drug. Now we'll move on to thiazide diuretics. So examples include bendroflumethiazide and indapamide. These are moderately potent diuretics. The diuretics act on the beginning of the distal convoluted tubules. They are known to be less potent than loop diuretics and are preferred in treating uncomplicated hypertension. They are known to be much more better tolerated than loop diuretics as well. So thiazides have a vasodilator effect, as the initial fall of blood pressure results from the decreased volume, which is caused by diuresis. They bind onto the chloride site of the distal tubule, which then inhibits the active chloride reabsorption via the sodium chloride cotransporter. This results in an increase in excretion of sodium chloride and water in the urine. The resulting contraction of blood volume stimulates the renin secretion, leading to angiotensin formation and the secretion of aldosterone. Some of the indications include mild to moderate heart failure. Bendroflumethiazide can be used in this case, edema, and hypertension. Bendroflumethiazide is no longer considered the first line for hypertension as a thiazide diuretic. Some of the cautions includes the exacerbation of diabetes, gout, and systemic lupus erythematosus due to the interference of the hypertonic urine. Some of the side effects include mild gastrointestinal disturbances, postural hypotension, hyperglycemia. Indapamide is best for diabetic patients as it causes less metabolic disturbances, and it can cause electrolyte disturbances as well. In terms of the pharmacokinetics, they are rapidly absorbed after oral administration. They act within 1 to 2 hours. They're heavily protein bound. The maximum effect after 4 hours, and duration of action is around 12 hours. And they can be administered once daily in the morning. Finally, we'll move on to potassium sparing diuretics. Examples include spironolactone, eplerenone, and amiloride hydrochloride. So these work by antagonizing aldosterone in the distant renal tubules. Spironolactone is usually combined with other diuretics, as on its own it's a weak diuretic. Potassium sparing diuretics inhibit the effect of aldosterone by competing for the intracellular aldosterone receptor in the distal tubule cells. Aldosterone is a hormone that retains sodium and excretes potassium in the kidneys. Spironolactone binds primarily through competitive binding of the receptors at the aldosterone exchange site in the distal convoluted tubule. This increases the secretion of water and sodium whilst decreasing excretion of potassium. Spironolactone and eplerenone compete with aldosterone for its receptor, whereas amiloride acts by blocking the sodium channels controlled by the aldosterone's protein mediator. Some of the indications include edema, resistant persistent hypertension, primary hyperaldosteronism, in Con syndrome, hypokalemia, moderate to severe heart failure in low doses, and secondary hyperaldosteronism caused by hepatic cirrhosis. Contraindications, so hyperkalemia again, so you need to monitor potassium levels in severe heart failure. In terms of the pharmacokinetics for potassium sparing diuretics, you have the drug rapidly absorbed from the GI tract. Food increases its bioavailability. 90% is bound to plasma proteins, and the half-life is around 10 minutes. However, it has an active metabolite which has a half-life for around 16 hours. Because food can affect the bioavailability, food would increase the bioavailability of spironolactone. It may decrease potassium levels, so salt substitutes containing potassium may increase the risk of hyperkalemia. Thank you for listening to my video. Hopefully you've learned something today. I've tried my best to explain the diuretics as best as I could. Please don't forget to like, subscribe and share.